From Diamond Pharmacy Services, this is PodcastRX, a monthly show that takes you behind the counter of the nation's largest correctional pharmacy provider. We bring you conversations with pharmacists, nurses, managers, and other Diamond staff about the topics and issues we see in corrections, long-term care, and community health settings. Our chats aren't limited to purely pharmacy topics, and they aren't strictly clinical either. So if you're a healthcare provider or just enjoy healthcare podcasts, we think you'll enjoy this show.
So it's a pleasure to welcome the entire Optics Clinical Pharmacy team live and in person here to PodcastRX. And if you wouldn't mind, if you could go around and introduce yourselves, starting with you, Zane.
I'm Zane Gray. I'm the clinical pharmacy supervisor, and I've been with Diamond Pharmacy for 9 years.
I'm Chris Bender. I'm a board-certified ambulatory care pharmacist. I've been with Diamond for 4 years.
I'm Henry. I'm a board-certified pharmacotherapy specialist and a board-certified ambulatory care pharmacist. I've been with Diamond for about 11 months now.
Hi, I'm Steve. I am a board-certified geriatric pharmacist. I've been with Diamond for almost 7 years now.
Hi, I'm Nancy Chia. I am a clinical pharmacist and I have been with Diamond for 3 months now.
3 months, welcome aboard.
Thank you.
Throw the rules.
So just about a month ago, we knew you all collectively as the Diamond Drug Info Center, and that'd been the name of your organization now for the past 6 years, right? But you've been rechristened as the Office of Pharmacy Therapeutics and Integrated Clinical Services, or Optics. So I think for anyone listening who's new to all of this, and there's probably going to be a fair amount of those who are, we got to ask, what is Optics? And what do you provide as clinical pharmacists for Diamond customers?
So the Optics team is the clinical team within Diamond Pharmacy that is responsible for all the clinical initiatives. So we're not responsible for dispensing, but we go and do a lot of the stuff on the back end with regards to dispensing, making sure that everything operationally, we work with operations to make sure everything's being safe and everything we're doing is clinically sound. We also are the external clinical team for Diamond. So when we work with our partners, it's primarily the Optics team that's reaching out, working from a clinical standpoint.
So I think it's also important to understand what Optics does. We have to understand the Diamond Drug Information Center. So why the name change and what was the inspiration behind the changes?
So the Drug Information Center was, the initial idea came from filling a need. So we identified there's not a lot of clinical, there wasn't a dedicated clinical team within Diamond, particularly for our correctional book of business and those customers. So now we wanted to develop something, and that was originally the Drug Information Center. And it was kind of fulfilling the need where we had a space for our nurses and physicians we work with to reach out and ask clinical questions to us. Filling that like what typically you would see in a outpatient setting or an acute care setting where you would have a clinical pharmacist available to you. In a lot of our facilities, they don't have that. So we built that out with the Drug Information Center.
You bridged that gap, and it was more, is it fair to say it was more of a passive service that if the providers on site wanted to talk to you, they could, but if not, that was the extent of it.
Correct. That is the biggest thing. Is previously it was very passive. It was like the problems were coming to us, and we weren't looking out and trying to address items that needed to be addressed. So yeah, it's much more passive in nature.
So when did you realize, and Steve, you go way back to the original formation of the group, when did you realize that it was time to refresh or, in this case, retire the Drug Information Center for something more active? Was it something external from customers that they were saying to you? Was it trends in pharmacy practice? Was it all those things, or was it just looking inward and saying, hey, how can we do this better?
It really started off as a kind of looking inward and seeing what are we doing right now? Does it meet the ideas of what a drug information pharmacist would do? Or are we doing more now? And kind of whenever I looked at what job descriptions were for drug information pharmacists, I identified we're doing way more than that now. We're now reaching out and we're actually getting to the patient care level. And then it was difficult to explain to our partners when we say drug information, it's not just drug information. So I just decided it was time for a rebrand.
Yeah. So it sounds like it all came about kind of organically, really.
Yeah.
Just started taking on more and.
Yeah, as the job description built on, and we were being tasked to do so much more, drug information didn't cut it, really.
Right. But at the same time, and we'll get into this more later, you were really flexing your clinical muscles more so
Yeah.
at the time, which had to be great. So the name Optics, how did it come about then?
Just throwing I would say throwing a lot of things at the wall, but it was just, we sat there and I worked with Matt Risco, and we kind of like talked about what we were doing and what keywords we wanted in our name going forward. And a lot of those names, when you're kind of spelling them out and you're looking at acronyms, and it just kind of fit, Optics was the one, because it does encapsulate everything we want to do. That's why we kind of went with that for an acronym.
And I think it's important just to add a little bit onto that. One of the key words that, at least what I gathered from your discussions with Matt, was integrated.
Yeah.
Because that's kind of the role that we're playing more so now, as opposed to, like you said before, it was more of a passive. They could sort of like catch you in the hallway, proverbially, so to speak, and call you and ask you a quick question. But now we're positioning ourselves more as an integrated part of the care team for the correctional and, both sides of the business.
And I'm glad you said that, because that leads perfectly into my next question, which is, of course, that direct patient care. That's probably the biggest part of the new Optics rebranding. So, and I'll open this up to all of you, but can you give some examples of how you're now weaving that clinical expertise into more direct patient care compared to what you were doing in the Drug Information Center?
Yeah, I'll speak first. Obviously, we do a lot in terms of, we're doing more now in terms of chronic care clinic, where we're assisting providers in how, we're doing it virtually, of course, through our various clinical modules, where we help them better, do their patient care with their chronic care clinics and whatnot, where we from afar kind of assist in terms of developing care plans, assessing patients, and providing them with resources and information that they need to kind of like speed up their clinic workflow in that regard.
If I could dovetail 1 second on what Zane said earlier too, as far as the new system now being more proactive as opposed to reactive, we're now engaged in processes. For example, we can identify patients who need those services, like a diabetic patient or a heart failure patient or someone who has hypertension. So we're not necessarily waiting for the provider to request information from us, meaning the old school drug information. Mm-hmm. We're actually seeking them out and suggesting that maybe we can actually help with this patient care on a chronic basis.
I just joined the team a couple of months ago, so I wasn't really familiar with what they were doing in the past. But just seeing what we're doing now with patient care, doing disease state management like diabetes, hypertension, asthma, and COPD, I feel like, as Steve mentioned, like seeking out those patients, making sure that they're getting the care that they need and stuff like that. So, yeah.
Yeah, and just another piece on the integrated part. There's a lot of different practical aspects in our pharmacy career that we've learned throughout pharmacy school, like, how are these drugs made? How are they priced? How are they sent out? How are they stored? How are they, acquired? So overall, like in my experience in the hospital, like those moving parts aren't really something that we have to really think about or care about. But, when we move towards this space of, catering clinical services to these different providers in places that could be 10 miles away or 1,000 miles away, not only do we collect a lot of like the different, data points that pertain to the patient, but we also deliver a lot of practical points where, these things are, we need to check on these things, we need to make sure that these things happen, and, like many different things, like there's a lot of different moving parts that have to happen within like an institutionalized setting to be able to decide on a certain type of pharmacotherapy, whereas these physicians out 1,000 miles away in a rural area or a rural practice area, they don't really have the resources or even the perspective or the expertise to have someone be like, hey, you need to do X, Y, or Z before you land on certain therapies. Mm-hmm. That perspective and that professional opinion is something that we provide for them and helps them to basically decide what's the right treatment for the right patient. So, yeah.
And a big benefit to us is, since we have so many patients, we've been asked all these questions, we can implement and give that expertise to all these varying scenarios, all these different sites, because more than likely we've been asked it once, twice, 100 times before. So it's very easy and it's very helpful for that we can get involved now more actively.
Yeah, and very easy to build that data out.
Yeah.
Yeah.
In a way, to lend a phrase from another, from another company, so to speak, we've seen it because we are optics, bump it up.
This vendor will be back on. And every night after that.
Yeah.
But all that said, and what you're talking about, how you're feeling that role with your clinical expertise as pharmacists, all told, in like the institutional world, especially where you guys live, are clinical pharmacists, are they getting their due? Are they, right now, they sort of overlooked as a clinical resource overall? And are you, as optics, are you looking to improve that perception?
I would probably say in the correctional setting where we primarily work, the clinical pharmacist is not utilized to the level. And I think that it needs to be. And I think the reason why is a lot of cost prohibitive. It's that people view it as cost prohibitive. And also, a lot of times, whenever you implement clinical pharmacy and it's a clinical pharmacist on site too, they start doing things that you didn't hire them to do. They start doing other tasks, so they're not really operating as a clinical pharmacist. Like for us, since our sole role is that's why we're trying to build that out and trying to show them that there is a model here that clinical pharmacy can work, and try to better incorporate that into our different facilities. But I do think it is a very underutilized, clinical pharmacists are very underutilized, especially in the correctional setting. You have so many patients, and a lot of these facilities have 0 pharmacists in them.
Yeah.
Or even involved with their care.
And I think it's interesting you said about cost prohibitive, because ultimately clinical pharmacy, like a group like optics, is touted for the cost savings benefit of it ultimately in the long run.
Right. And I think when you look at it on the outside at the label, without thinking about the other ancillary benefits that come from clinical pharmacy, you may have a bit of, you could have a bit of sticker shock because you don't understand how the cost is justified. But as we've seen out in the, however you want to put it, the outside, the real world type setting, we're just introducing what has already been happening in terms of clinical pharmacy becoming integrated into clinical practice. We're bringing it into the correctional care, which has for many years been an insulated silo. But I think as time goes on with us integrating and bringing our services to others, I think it'll be just as commonplace as it is on the outside.
I'd be interested though to see what Nancy and Henry think, because they were clinical pharmacists in the outside of the correctional setting too. So, what are your opinions on that, and how your previous experience was?
Yeah, I think for me, pharmacy has changed so much in the past couple of years. And most of the time when people think of pharmacy or pharmacist, the perception that they have is that of a traditional dispensing pharmacist. So they're unaware of the clinical benefit or the things that a clinical pharmacist can contribute to a team. So I feel like lack of awareness. Some providers have not worked in direct contact with the pharmacist before. In my previous work setting, which was residency, it was I don't want to say it's a constant battle, but constant education to bring awareness to the services that we do provide. Just letting them know that we're here. These are the things that we do. These are the services that we do. We usually have PG, first year medical students, when they come on rotations, they're doing their rotations. We usually have topic discussions with them. This is our team. This is what pharmacy is here for. These are the services that we provide, which is the same thing that we do with optics. But just improving awareness and also making sure that the experience or the interactions that we have with the provider is a positive one. Because if you're the first pharmacist that a physician interacts with, his perception of pharmacy is going to carry it through. So you just want to make sure that you're setting, I don't know what I'm looking for, but when you're working with a physician, it's not just you. It's you're carrying the whole pharmacist with you. Okay, this is a pharmacy department. This is what they're doing. So just making sure that the experience is a positive one, and also competent as well.
representing the whole
Yeah,
profession.
representing the whole profession essentially. Because if they have a bad interaction with one pharmacist, it's just no, I'll do it myself. There's no value in that. But just constantly providing your customers with like value, improving outcomes, reducing costs. Your work is gonna speak for itself eventually.
Right. Steve, you look like you wanted to chime in.
Yeah, one thing I wanted to say is, being the older spokesman of the group, I practice whatever there was, as Chris alluded to, this has happened in the past and previous venues, hospital settings and what have you, where clinical pharmacists would round with physicians, for example, they would make clinical recommendations, you would see patients on a proactive basis, and I was there, pretty much since the infancy, basically, from all that, as far as, being able to provide our services to, patient care, if you will. But one of the things I think of why optics is more interesting, and again, going off of what Chris was saying, as far as being able to provide these services to a broad base of people. Now, we're not able to be in the facilities necessarily. We don't actually have to see the patients personally, one-on-one, but with technology advances and the computer generation being what it is, we're now able to help manage or assist in the management of a lot of different patients, hundreds of patients literally, from our own place here in Indiana. So we don't necessarily have to be physically present on site, which definitely helps.
Yeah, most definitely. And you brought up the technological side of it. One of the new optics services, one of the banner services in your marketing materials is something called the Medication Surveillance Monitoring Program. I wondered if you guys could tell me more about how this was developed and how it works.
Okay, so the surveillance program comes from us it started off fulfilling a need, just the same as Drug Information Center did. We identified a lot of things were happening in the pharmacy and we wanted to solve the problem. As soon as we did that, we realized, okay, this technology that we have can be used proactively too. So same with the optics team. We identified, okay, let's figure out some proactive uses for this. It might not be a problem now that we know of, but now we're going to implement some new technology. And basically what the surveillance program is this background technology that's always happening every day. It's constantly running through all the prescriptions that are being dispensed, the orders coming into the pharmacy, making sure they meet certain safety criteria, identifying if there's something that requires intervention from one of the clinical pharmacists or from the account pharmacist. It's kind of just constantly looking through. And this service is just a part of the basic doing business with Diamond. All our partners are already benefiting from it. They don't know, you may not know it, but all of us are implementing it, and it's constantly growing too. As we identify, hey, this would be a cool thing to implement and report on or monitor within the pharmacy, we're constantly building out new programs and expanding on what's being offered with this program, the surveillance program.
That's fantastic, and it sounds like a lot of automation going on.
Oh yeah, definitely a lot of automated pieces to it.
And there's two things that I really like about it. It's not necessarily changing the spirit of the way that pharmacists handle their business. In the community, you're always screening for those types of things. As you get this one prescription across your computer, you check it against the background. This is a more efficient use of data and technology to scan the entire swath of business and identify every single instance of a particular duplication or interaction. So it's efficient. Another thing that I really like about it is that it drives us to contact the facility to address these things. And what I've noticed throughout my own personal interactions is that they were not aware that we, A, do these things, and B, that we were accessible as pharmacists. So in a way, it kind of opens up those lines of communication and relationships that we have with providers, nursing staff, or other people in the facility. And I know that I've personally developed better relationships, and I now have people contact me directly or contact the department directly who didn't know that they could beforehand, simply because we're just doing this proactive service.
So with all that in mind, from an overall service perspective, then what would you say is the most noticeable change that Diamond customers are going to see as they work with optics going forward, as compared to when they were working with the Drug Information Center?
So, whenever I would kind of talk about Diamond Pharmacy, previously before the optics department, I would say if you hear from somebody at Diamond Pharmacy, something is wrong. Because you should never hear from, they want their pharmacy to be in the background. They want to make sure they receive all their medications every day, and They just want to make sure everything's being done correctly, and that's why they hire Diamond. They don't want to deal with it.
Yeah.
They don't want to deal with the whole pharmacy business. Now, whenever the optics team comes in, we're going to be reaching out and we're going to be talking to you more, and that's okay. That's just the change in the model that we're implementing and how we're doing business now is we want to be actively participating in the care for the patient. So it's okay if Diamond reaches out and you hear from a clinical pharmacist at Diamond.
Right, because that in the case that you talked about, that's actually a call for improvement. There's something to identify that can be improved.
Yeah. Every phone call is an opportunity for improvement.
Yeah. And for as much as we've talked about optics serving the external facilities for customers, it's also very important too that what optics does for internally for Diamond. So can you tell us more about that?
Who wants to go? Anyone want to talk about internal?
Yeah, I think it's awesome because I have a lot of experience with this, having discussions with many internal people, and that's not just whether it be the pharmacists, whether it be data entry technicians. I would say that, speaking personally, but probably relates to the rest of the group as well, is we serve as a primary source of information. Often the production pharmacists will come to us with odd questions or trends that they're seeing in prescriptions and orders, questionable, that might be questionable, or just they might be noticing a slight change in dispensing habits and stuff like that. And we can be there to give them information as to whether or not that's right or wrong, providing education on something new that might be happening, whether or not that's justified. So I would say, our primary role internally would be to provide them with either information or support to justify make them feel better about dispensing.
Sure. Also, marketing departments with podcasts. That's also
yes.
But I mean, like what Nancy said is true, especially with our internal team. She talked about it externally, but every interaction we have internally with somebody here, whether it be one of our technicians or a pharmacist, is again relationship building and showing them what we can do and promoting ourselves. So we do take every one of those interventions and interactions very seriously when we're doing them. Or some other things we do that people might not be aware of is we participate in drug recalls, we participate in O's for the entire pharmacy. So if something is owed or on manufactured back order, we're the one that's sitting in there trying to address that. So in a pharmacy as big as us, it's a lot of O's and a lot of manufactured back orders that we deal with. Mm-hmm. So trying to solve that.
And we have to figure out alternatives. We have to help figure out alternatives for those, because unfortunately some of the shortages just don't resolve overnight. So we need to figure out a way to address that, how to adequately treat that certain disease state that you were using that for. So that's kind of where we come into. We find ways to pivot when necessary.
Pivot very quickly. It's not just like, okay, we did this, now we have to solve the problem that we've now created for ourselves.
It's an efficiency of resources too, I think, because our department is able to focus on issues like that. Mm-hmm. So not only do we help our external customers and allow them to be more efficient and the providers to see more patients, because we're able to now be more involved with patient care on an inpatient or an internal perspective. If we handle some more of those tougher issues, they consider us the drug experts, if you will. We're all pharmacists by definition for the most part, but yet they're able to focus on their processes and be able to get the prescriptions ready and basically get the drug out the door. And some of those other issues can be handled by the drug experts, that we can spend more time and dig into those situations even deeper if we needed to. So we help everybody basically work more efficiently on some levels.
And another big one, we were just talking about it today, was we do training for our pharmacists that are in charge of our correctional accounts. So they get questions all the time, and they'll forward us the questions a lot of times. So we've started doing education for them on different disease states, different topics that come up continually for them. So we're trying to make them start thinking more clinically whenever they're in these conversations as well. So maybe they can just answer the question because we've now educated them on it. So we're kind of working in tandem with them a lot of times.
Yeah, to piggyback off of that, we're able to equip them with the tools and the ammunition to be able to go to the front lines and basically say, yes, absolutely, that is something we should be doing. That's the standard of care in a world where literature is constantly coming out, changing, practice changes, and it's just, just the ability to give our consultants the ammunition to just be like, boom, yes, that's appropriate, versus no, that's not. So
they can answer very quickly instead of maybe saying I don't know, which isn't usually a good response.